بسم الله الرحمن الرحيم. معكم دكتور أمين نوار، مدرس طب وجراحة العين في جامعة طنطا. النهارده بإذن الله هنتكلم عن الفيجوال باثواي والكلينيكال ابلكيشنز بتاعته، وبعض الحاجات عن البيبيلاري ديس اوردرز، وايه الحاجات اللي هي تبقى ابلايد كلينيكالي على البيبل واللايت ريفلكس والموست امبورتنت ريفلكسز including light reflex والنير ريفلكس، وبعض البيبيلاري abnormalities اللي هي related للفيجوال باثواي. في البداية عشان نبقى فاهمين الكومبوننتس فيجوال باثواي بتاعتنا، احنا عندنا في 7 ايتمز بيمثلوا الكومبوننتس بتوع الفيجوال باثواي، بداية من الريتنا بال10 لايرز بتاعتها، بداية من الاي ال ام لحد الريتينال بيجمنت ابيثيليوم، الاوبتيك نيرف، بعد كده الاوبتيك كيازما، بعد كده الاوبتيك تراكت، اللاترال جينيكليد بودي اللي هو جزء مهم جدا ونيوكليوس مهمة جدا في الثالاموس، والاوبتيك راديشن، and finally the occipital cortex او الفيجوال كورتكس. عشان ابدا استعرض كل كومبوننت من دول من المكونات بتاعه الفيجوال باثواي، دي رسمه بتمثل الجلوب وازاي الاوبتيك نيرف بيمرج فروم ذا ريتنا، ازاي الجانجليون سيلز بتديني الاكسونز بتاعتها، بتديني النيرف فايبر لاير، ومنها بتيمرج از ذا اوبتيك نيرف، والاوبتيك نيرف بيكمل في الاستراكشر انتراكرينيال بتاعه لحد ما يوصل للاوبتيك. دي صورة هيستوباثولوجيكالي بتمثل الهيستولوجي اوف ذا ريتنا بال10 لايرز بتاعتهم زي ما قلنا. بعد اول كومبوننت في الايه في الفيجوال باثواي، من الريتنا بيطلع بعد كده بيمرج الاوبتيك نيرف، والاوبتيك نيرف لما نيجي نتكلم عنه اناتوميكالي بنقول ان هو حوالي تقريبا 5 سم في اللينس، حوالي 5 مللي في الدايمتر، 4 بيتكون من 4 main parts. الاوبتيك نيرف بيتكون من 4 اجزاء، في جزء منه انترا اوكلر اللي هو ال 0.1 سنتيمتر، اللي هو الجزء اللي بنشوفه في انترا اوكلرلي وانا بفحص العين. بعد كده بيعدي في الاوربت حاجه بنسميها الانترا اوربيتال بارت بطول حوالي 3 سم تقريبا، بيخش الاوبتيك كانال بسميه الانترا كاناليكولار بارت، وبيكمل بعد كده لحاجه اسمها الانترا كرينيال بارت، بعد كده اللي هو بيروح تو ريلاي وينتهي في حاجه اسمها الاوبتيك كازما. بنقول الاوبتيك نيرف هو طوله اوفرول لينس بتاعه about 5 سنتيمتر، عندنا تقريبا مليون لمليون و200 الف اكسون موجودين في الاوبتيك نيرف، بيمرج فروم ذا ريتنا ويوصلوا من خلال الانتراكرينيال بارت بتاعه للاوبتيك كازما. ده الشكل كده بيمثل الاوبتيك نيرف وال blood supply بتاعه including the central retinal artery and the central retinal vein، وازاي ان هم بيعملوا piercing للديورا والاركنويد والبيا ماتر تقريبا 12 مللي behind the lamina cerebrosa اللي هي الفاسكوليتشر، وبيكمل بعد كده الاوبتيك نيرف بالاربعه بارتس بتوعه لحد ما يوصل للاوبتيك كازما. الاوبتيك كازما لما نيجي نتكلم عنها هي عباره عن اولا بنقول ان هي oblong band of nerve fibers موجوده في الفلور of the third ventricle. دي بتحتوي على مجموعه من النيرف فايبرز هي الريلاي او site of the relay of the optic nerve، عشان يطلع منها بعد كده ويكمل الاوبتيك تراكت اللي بيكمل في الباس واي لحد اللاترال جينيكليد بودي. يبقى هي موجوده في الفلور بتاع الثيرد فنتركل. الاوبتيك كازما very important landmark، لان هي لما اجي ابص عليها بالمنظر دوت هلاقي ان this is the third ventricle and this is the optic chiasma including here the area of the base or the floor of the fourth of the third ventricle. الاوبتيك chiasma has a very important relation ان تحتها بنلاقي بنيز على طول البيتيوتري gland في السيلا تيرسكا connected intracranially what we call the infundibulum of the pituitary gland، وبالتالي this is a very important anatomical landmark اللي هي منطقة الأوبتيك كازما وما تحتيه من البيتيوتري body أو pituitary gland connected بحاجة بنسميها الانفundibulum. يبقى الأوبتيك كازما بتبقى lying over the pituitary gland، وبالتالي أي growing pituitary tumor can compress the optic chiasma and produce subsequent visual field effects زي ما هنشوف بعد كده. ده الشكل بتاع الاوبتيك كيازما، وهي واخده الفايبرز بتاعت الاوبتيك نيرف زي ما بنشوف كده، وبعد كده بنكمل بحاجه اسمها الاوبتيك تراكت. هنا البيهيفير، لما انا ابص على البيهيفير بتاع النيرف فايبرز في خلال الفيجوال باثواي هلاقي this is the retina، ودايما الريتنا عكس اتجاه الفيلد، وبالتالي ان النيزل part of the retina perceive the temporal field and the temporal or the lateral half of the retina perceive the nasal part of the visual field. بتكمل بعد كده الفايبرز through the optic nerve. في الاوبتيك كازما الفايبرز بتبيهيف ان النيزل fibers coming from the nasal part of the retina بتdecussate with the opposite fiber in the central part of the optic chiasma. However, the temporal fibers in the optic nerve pass uncrossed through the temporal part of the optic chiasma to pass to the ipsilateral optic tract. وبالتالي بنقول إن كل optic tract containing the contralateral nasal fibers from the contralateral optic nerve and the ipsilateral temporal fibers from the ipsilateral optic nerve like this. ده الشكل بتاع البيز بتاع البرين، وازاي الفيجوال باثواي زي ما قلنا ازاي ان النيزل field represented by the temporal retina and the temporal field represented by the nasal retina. This is the optic nerve decussating in the optic chiasma. This is the optic tract. Beneath the optic chiasma here is the pituitary gland, and this is, by the way, this is the third nerve. Another section here in the base of the brain in the area of the sella turcica denoting here what أول حاجة المفروض زي ما قلنا إن pituitary gland lying over in an optic chiasma lying in this area. Beneath the pituitary gland, this is beneath the optic chiasma, there is the pituitary gland lying on the sella turcica, and this is the sphenoid bone. So we have three structures from above downwards: the optic chiasma lying over the pituitary gland, and then beneath them is the sphenoid sinus. What about the lateral relations of the optic chiasma? Here we find a very important structure called the cavernous sinus. Cavernous sinus, it contains two structures running inside the cavernous sinus and four main structures running in the lateral wall of the cavernous sinus. جوه الكافيرنس ساينس فيها artery كبير ونيرف صغير اللي هو internal carotid artery and the abducent nerve or the sixth nerve. This is the internal carotid artery lying within the cavity of the cavernous sinus and projecting on the lateral aspect of the optic chiasma. On the lateral wall of the cavernous sinus, here we find the following nerves: the third nerve and the fourth nerve and the first and the second divisions of the trigeminal nerve, ophthalmic and the maxillary divisions. So we have from above downwards the third, the fourth and the fifth cranial nerves in the lateral wall of the cavernous sinus. So in enlarging pituitary gland lesion can compress upward over the base of the optic chiasma, producing visual field effect, and enlarges laterally to compress on the cavernous sinus, compressing the internal carotid artery, compressing the three main nerves responsible for the ocular motility. So it can result into what we call ophthalmoplegia and ocular motility defect, and also sensory loss and sensory manifestations along the distribution of the first and the second divisions of the trigeminal nerve. This is another sagittal section of the brain showing this is the third ventricle, the floor of the third ventricle lying here, the optic chiasma, and this is this is the pituitary gland as we see here, connected intracranially through the infundibulum, third ventricle, optic chiasma, and beneath it the pituitary gland. The optic tract anatomically, it emerges from the optic chiasma. I have said it contains the ipsilateral temporal fibers from the temporal part of the retina and the contralateral nasal fibers from the contralateral part of the retina as well, and then pass in close relation to what we call the pyramidal tract and the cerebral peduncle to terminate in what we call the lateral geniculate body. What about the lateral geniculate body? The lateral geniculate body is the nucleus inside the thalamus. So anatomically, it is related to the thalamus. It's a very important nucleus within the thalamus. The thalamus contains two important nuclei: the lateral geniculate body for the visual pathway and the medial geniculate body for the auditory pathway. From the lateral geniculate body, the fibers pass through the optic radiation like here, and the optic radiation pass through the parietal and the temporal lobe to reach the occipital cortex like this. These are the fibers of the optic radiation right here. Finally, and the final the final destination for the visual pathway is the occipital cortex that lies on the medial aspect of the occipital cortex, like here, with a slight extension over the temporal lobe. So the large area of representation of the visual cortex lies on the medial aspect of the occipital lobe, while with a slight and very slight extension over the temporal or over the lateral surface of the occipital lobe. So this area has a very rich blood supply from the middle and the posterior cerebral artery. So that's the cause for what we call it macular sparing in visual cortex lesions. What about the analysis of the fibers of the visual pathway? As we see here for the visual pathway, how the fibers within the visual pathway represent the visual field in clinical practice. How the fibers pass within the optic nerve, and how the fibers pass within the optic chiasma, and through all parts, all other components of the visual pathway till it reaches finally the visual cortex. This is a very important diagram. Actually, this diagram illustrates the visual field effects subsequent to damage of any part of the visual pathway. First, the optic nerve contains the whole of the fibers, as we said here. So in lesion in site A right here, so we cut all the fibers from the left eye so it can produce what we call total scotoma and complete blindness here in this area. So in lesion in position A, here it is, we find actually complete blindness like here. In lesion B, in the central part of the optic chiasm that contains the decussating nasal fibers from each side, so it can produce what we call heteronymous hemianopia. Heteronymous means the two opposite sides of the visual fields are affected. So in lesion here, lesion B, in the central part of the optic chiasma, which is mainly caused by enlarging pituitary lesions from the site, can compress. So in case of pituitary adenoma, the central part of the optic chiasma is affected and is compressing the nasal fibers of the retina, and hence can produce by temporal hemianopia. However, if the temporal aspect of the optic chiasma is affected, as in lesion C, as by carotid artery, internal carotid artery aneurysm, can produce what we call nasal hemianopia, or what we call here nasal hemianopia. If both sides are affected, can produce binasal hemianopia. So lesion in the central part of the optic chiasma can produce by temporal hemianopia, while in the temporal aspect of the optic chiasma can produce nasal hemianopia. As we have mentioned, in lesion inside D, which is the optic tract, as it contains the ipsilateral nasal fibers and the ipsilateral temporal fibers, and the contralateral nasal fibers, so lesion here will produce contralateral homonymous hemianopia on the opposite side. So in lesion in the left optic tract, it results into right homonymous hemianopia, and the left optic tract into right homonymous hemianopia. So left optic tract lesion produce right homonymous hemianopia, and left optic tract lesions produce right homonymous hemianopia. In the lateral geniculate body, lesion here produces the same effect of the optic tract by homonymous hemianopia. But in the optic radiation, we can divide it into two main parts. If the lesion in the side G affects the main part of the optic radiation, it contains the same fibers of the optic tract, so it produces similar lesion as optic tract lesions, what we call homonymous hemianopia. So left optic radiation, main optic radiation lesion, can produce right homonymous hemianopia. However, if the superior fibers that pass through the parietal lobe are only affected, it can produce what we call here inferior quadrantinopia. If the temporal fibers or the inferior fibers that pass through the temporal lobe are affected, produce superior quadrantinopia. So in lesions, again, to revise, In the optic tract, homonymous hemianopia on the contralateral side. In the main optic radiation, homonymous hemianopia on the contralateral side. However, if the superior fibers are affected only, can produce inferior quadrantinopia. If the inferior fibers are affected only, can produce superior quadrantinopia. In the visual cortex, it can produce here what we call homonymous hemianopia with macular sparing. As we have mentioned, the macula is spared due to double blood supply and the large area of representation. Now let's deal with different pupillary reflexes, and there are three main reflexes, what we call the light reflex and the near reflex and the sympathetic reflex. Three main reflexes and subsequent clinical applications for the visual or for the pupillary light reflex. Pupillary light reflex as a visual pathway begins here from the retina, optic nerve, optic chiasma, and then it leaves the lower part of the optic tract to pass to what we call here the pretectal nucleus. From each pretectal nucleus, the fibers pass to the Edinger-Westphal nucleus on both sides. So we have decussation here, and so we have direct light reflex and consensual light reflex. When one eye is affected, in the same pupil is constricted and the other pupil will constrict also. So we have direct and consensual light reflex. So we have here the light reflex, optic nerve, chiasma, optic tract, but it leaves the lower third of the optic tract to pass to the pretectal nucleus at the level of the midbrain, and then pass again to the Edinger-Westphal nucleus. From its fibers, the preganglionic fibers pass to the ciliary ganglion, and from it, the postganglionic fibers through the short ciliary nerves that supply the sphincter pupillae muscle and the ciliary muscle as well to produce pupillary constriction. The near reflex is much more similar to the visual pathway in that when the fibers pass here through the optic chiasma and the optic tract, they pass to reach the occipital cortex and from it pass to what we call the frontal eye field area. From the frontal premotor cortex or the frontal eye field area, the fibers here pass to the Edinger-Westphal nucleus indirectly without passing through the pretectal nucleus. So lesion in the pretectal nucleus can affect the light reflex without affection of the near reflex. So the fibers pass alike in the near reflex, the fibers pass in the same way as the visual pathway that it reaches the occipital cortex, and from the occipital cortex pass to the frontal eye field area and then to the Edinger-Westphal nucleus without passing through the pretectal nucleus. From these fibers, the fibers pass into two directions. One direction, preganglionic fibers to the ciliary ganglion, the same way as the light reflex to the sphincter pupillae muscle, and another one to the medial rectus subnucleus, and then to the medial rectus to produce convergence. So in near reflex, it is divided into convergence by contraction of the medial recti muscles, and accommodation by contraction of the ciliary muscle, and meiosis by contraction of the sphincter pupillae muscle. The sympathetic pathway is completely different away from the other near reflex and the light reflex. Here is the autonomic innervation of the eye. Now, this is the posterior hypothalamus, then pass descending fibers through what we call the ciliospinal center of Budge from seat 8 till thoracic 2 spinal segments. From it, preganglionic fibers pass here along the internal carotid artery and end here in what we call the superior cervical sympathetic ganglion. From it, the fibers of the postganglionic fibers pass through the long ciliary nerves to supply the dilator pupillae muscle. So we have hypothalamus, descending fibers, ciliospinal center C8 to T2, and then preganglionic fibers to the superior cervical sympathetic ganglion, long ciliary nerves, which are 2 in number, to supply the dilator pupillae muscle. Now, let's deal with the clinical applications on such reflexes. Here it is. This is the first one, what we call here the relative afferent pupil defects in cases of incomplete optic nerve damage or retinal damage, what we call Marcus gun pupil. What is the relative afferent pupillary conduction effect? This is a normal light reflex light shear. As we have said that we have direct and consensual light reflexes. First of all, this is during the dark pupillary dilatation. This is during the light pupillary constriction. So we will test here for the direct and the consensual pupillary reflex. This is a direct one. Notice here how this eye, like here, if we are stimulating one eye like this, it will produce direct and consensual light reflex like here. When I swing my light to the other eye, I produce the same. We have direct and consensual light reflex. This is the normal. This is the normal. What about the relative afferent pupillary conduction effect in case of incomplete damage of the optic nerve in one eye? Stimulation of the normal eye will cause constriction of both eyes. While swinging flashlight test, when I swung my light like here, as you notice here, this is the relative afferent pupillary conduction effect. When I stimulate the normal eye, both pupils will constrict. However, in a swinging flashlight test, this is when examining the normal eye, both pupils will constrict as the afferent and the efferent is intact. However, when swinging the light from this eye to the other eye will dilate instead of constriction. This is called what we call here relative afferent pupillary conduction defect. Yeah, okay, this is dilatation instead of constriction. So by swinging flashlight test, when I'm examining the diseased eye, there is no direct and consensual reflex. When I move my light to the sound eye, both pupils will constrict. When I move and swing my flashlight to the diseased eye rapidly, the diseased eye will dilate instead of constriction. This is called the Marcus gum pupil. Another one here is called the Argyll-Robertson pupil, which is a case of damage
Both
here
pupils are
in the
small in normal
pretectal
illumination.
nucleus.
They are sometimes
Actually,
irregular in shape
pretectal
and
nucleus
unequal in
lesions,
size. In the dark, the pupils are also
which
small,
is responsible for the
constricted.
light reflex, we find here the light reflex is absent. However,
The light
the
reflex
near
test.
reflex is preserved. The most important cause of Argyll-Robertson pupil
When the
here
light is shone
is
into the right
the
pupil, there is
neurocephalus.
no direct or
Notice
consensual
here there is
reflex
no
visible.
direct or consensual reflex as the pretectal nucleus is affected. No direct
There is no
and no
direct and
consensual
consensual
reflex. I'm
dilation when the
repeating,
light is
there is
removed
no
from the right
direct or
pupil.
consensual dilatation due
The
to
pupils are already
damage of the
constricted,
pretectal
and they do
nucleus.
not constrict any further with light.
But actually the near reflex is intact, so the near reflex is intact.
There is also no
Please
direct or
concentrate
consensual reflex
in
visible
this.
when
There
light
is
is shone
no
into the
direct or
left
consensual
pupil.
reflex again due to lesion of the pretectal nucleus.
There is again no direct or consensual dilation when the light is removed from the left pupil.
Again, please concentrate here. If the patient looks to a near object, you will find slight constriction that occur, indicating
The
intactness
Argyll-Robertson
of the
pupil with a
near
swinging light
reflex.
test.
This is called what we call here light near dissociation. So, in cases of light near dissociation,
When light is shone into
as
the right pupil,
this
no
one,
visible
in
response can be
Argyll-Robertson
observed
pupil,
from both
the light
pupils.
reflex is absent. However, the near reflex is preserved.
There is also no response when the light is moved to the left pupil. Both pupils are still small. Note that the pupils don't dilate when the light is moved. It is also the case in complete darkness.
When the patient looks to the near object,
test.
you will find slight constriction that occur in such
The
cases.
pupils are small in normal illumination, and they constrict slightly more in
there is a
response to
slight
the near
constriction that
target.
occurred with near vision.
But the
So,
pupils remain small
in
when the patient's
Argyll-Robertson
looking
pupil,
back at the
we
distance
are facing
target.
a case of disease and damage in the pretectal nucleus with absence of the light reflex and intactness of the near reflex. The most common cause is neurocephalus. Finally, what we call the Ades pupil. Ades pupil, this is a lesion in the post-ganglionic fibers, the short posterior ciliary nerves. So we have what we call the nervation hypersensitivity. It's mainly characterized by the light reflex is absent or sluggish, and the near reflex is present but we have facing tonic near reflex and tonic accommodation. What's meant by tonic near reflex? It means that when the patient here looks to a near object, he takes a lot of time to be able to redilate and refocus on a distant object. So we have absent light reflex with tonic near reflex. As the lesion here in the short posterior ciliary nerves, we are facing physiologically by the phenomena called denervation hypersensitivity. In general, we have a very important test called pilocarpine test. If we place pilocarpine test with a very minimal concentration, 0.125%, normally it doesn't constrict the pupil, but here we find extensive constriction of the pupil, what we call denervation hypersensitivity. This is the pilocarpine test, which is conclusive for the ADES. If we are facing here, this is the normal light reflex, and here to the right, this is slow tonic reflex to the light. You see, the pupil is dilated, no pupillary constriction. This is the same as the gyrops pupil, absent light reflex, but with preserved near reflex. Notice how this dilated pupil will constrict with very minimal concentration of pilocarpine. This is called the pilocarpine test. Again, this is slow tonic response to light. Okay, imagine and notice how the pupil will markedly constrict after installation of this very small concentration. This is the left eye, the sound eye, no change the pupil size. This is the other eye with marked pupillary constriction. This is called ADES pupil. So we have two main types of light near dissociation, which the light reflex is absent and the near reflex is preserved, are Giles-Robertson pupil and the ADES pupil. ADES pupil with absent deep tender reflexes, we call it Holmes-ADES syndrome. And thank you so much.